we can improve health and promotion by things we do in society or with education, but here we're talking about more of the environment, and that could include a program space on your site, like a garden for patients or a garden for staff, or maybe we have identified this need and it's going to be a new clinic or one room for staff respite or lactation for nursing mothers. And the context and the settings for this can be really varied, not only for healthcare facilities, but for all facility types. Some of these principles apply. And if we look at where we are today, Daria shared some example literature reviews from the last 2 or 3 years, which are really good. And they're actually building upon previous research, like she mentioned, and this is from 2008 by Roger Ulrich and the team from Texas A&M and others, where the outcomes and the design strategies have actually not changed that much from this to those recent literature reviews. We're getting better evidence, we're investigating some slightly more detailed topics, but the relationships and the type of outcomes are not that different. And one is the is a private patient room, a single bed room. So if you see on the left of the chart, there's more outcomes, double star, strong evidence supporting single bed rooms. But then we've got daylight, adequate artificial lighting, views of nature, all those things can have associated positive effects regarding depression or patient length of stay, patient sleep and pain and falls, staff injuries and staff stress. So there's a lot of outcomes that we can affect. And we'll talk about the interplay between those here in the next few minutes. So this is the one that does seem to have the strongest evidence. No design strategy and outcome you can say should apply everywhere. So this may be most common for inpatient or even for acute care, but also the evidence is applicable for rehabilitation or mental health. For each of these, there are pros and cons, but gradually we're seeing a shift toward this because of the benefits you get. And probably another topic that has about the best evidence is daylight and outdoor views of nature. Nearly all settings this can be applicable for. It can reduce stress, reduce pain, or reduce depression, and even other factors. I love this one study from 2014 that found that nurses' communication and laughter increased when they were in rooms with windows. The next topic is nature imagery and art. This is following on daylight. If nature views, real outdoor views in daylight may be optimal. Some spaces cannot have that for certain reasons. Maybe an endoscopy, colonoscopy room needs to be a little bit darker so the clinicians can see the screens for their scopes. And then art can be throughout the whole hospital. Some of it, like this picture, can have a backlit lighting of a nature image in the ceiling. And these are positive to reduce stress and anxiety and probably also help staff well-being also. And next topic is wayfinding. This means how easy is it for you to find your way when you're coming to a healthcare facility? Because many healthcare facilities are large and complicated. They may be added in many buildings over many years, and it's easy to get lost, like a maze. And that can be stressful, can take patients more time. Sometimes they might get a delay in their care or even miss their care. It may be causing interruptions for staff, having to answer directions and distracting from their work. So having good, clear wayfinding can reduce stress for all these parties, improve care access, even improve security in facility so people are going in the right areas where they're supposed to and not wandering into other areas. In each of these scenarios, you might need a different level of focus, less distraction. You might need a different level of calm. Um, and all of these can be affected not only by daylight that we've talked about, but also by the sound. One more example gets in a little more depth. These diagrams are acute care inpatient units. So this is talking about staff well-being. If you're a nurse or assistant nurse, it's important that you can see your patients so you can take care of them. It's also important that you can see your colleagues so you can get assistance, you can support each other, you can participate in mentoring, you can call for help quickly if needed. And so this really affects your care quality, your collaboration, maybe affects your staff or even the cost of the facility if you have to keep hiring new staff because they're not satisfied. So there's some evidence related to design, not as much as for medicine, but we have all these design factors and we know that they have some kind of impact, whether it's on the organization or on staff or patients, but it's complex. If you are working at a hospital or you're a designer, how do you know which of these design factors has which of these impacts? It can be complex. So there's all these factors coming together, not just between relating the design to the outcome, but also knowing how you can rely on this and pull the pieces together. So one of the factors, and like Daria mentioned also, is the evidence quality, is we want to design based on the best evidence that we have. So as she mentioned on the top right might be meta-analysis, systematic reviews, and that can be informing clinical guidelines. And then we don't have that in the design field in the same way, but we can have evidence the best we can. These are all really good things to pull evidence together, maybe informing a single project, and that's valuable. It's probably better and less biased than just personal experience. So these are good things. And they can inform some of these guidelines that we do have in design and regulations. And we do have in the design field, we have a few randomized controlled trials and some systematic literature reviews for some topics. So we can keep pulling from those, and hopefully those will keep informing the guidelines that we use also. Here's an example I want to mention how do people pull these different interventions together to make an outcome or make a guideline. So in medicine, sometimes they have a topic called, they call it a bundle. Maybe if you're placing a central line for an IV for a patient, a central line bundle, maybe you do these 3 or 4 things, 5 things in terms of how you clean your hands, how you open the supply pack, how you talk to the patient. All these things, when you do them together reliably, that it can improve the patient outcome, such as reducing infection prevention. However, in design, we usually have multiple interventions in a study, and then usually it'll have multiple outcomes in a single research study. And if you look at a different research study, they might have different interventions that they're trying to do, or they might have different outcomes that they're studying. So it cannot be bundled together as effectively and reliably as it can be in medicine. Back around 2006, while Roger Ulrich and team were doing their literature review, around that same time, architect Stefan Lundin at White was designing this hospital. And so the evidence research literature was not very robust at that time, and Stefan could not rely on it. But he knew some of the good principles from his intuition, and he had a lot of practice-based experience. So he designed this facility that their team did that turned out to be really great for patients. And so a conversation later with Roger Ulrich, he said, Stefan, how did you design this when all the research evidence was just emerging at that time? You incorporated all the evidence principles without even knowing them. And I think we hope we can do that as designers. And so there's this dialogue with Kirk Hamilton also made this chart, how there's this interplay of using what evidence you can, getting your best practices pulled together and talking to clinicians. And sometimes it becomes evidence over time. And that happened in this case. And when we're trying to pull all these together to inform the best design possible, there's always this tension about what is more important. For example, if you have that single bed room, that may be very good for infection prevention, for quiet, for privacy, but it may be not good for staff awareness or for some safety aspects. So there's this tension that can a design be flexible and robust to accommodate all of your goals? Hopefully we can, and sometimes it can, but sometimes it can't. So we have to balance this tension and also the cost factors. So I like these charts that Daria had pulled together, and I wanted to compare them again for evidence-based medicine on the left and evidence-based design on the right. We can actually have very similar frameworks where you're pulling together a person's expertise or team's expertise with your evidence from science and research, as well as your specific needs of the patient or the project and how it all fits into the broader context. However, in evidence-based design, often we may have less evidence, at least compared to medicine. Yeah, this is talking about the prototype designs and how the client needs and preferences and resources may be a little different. And then lastly, we'll look here at the evidence-based design application process that I think could work for all project types, really that we have our goal, the broader goal being patient and staff outcomes and well-being, but get a more specific goal. We want to reduce patient injuries or staff injuries. Once we define those objectives, then we can review the research literature or any guidelines, and then talk together also with the patients and the staff that we may be designing for. And then we can do some testing or simulation or pilot projects to do preliminary ideas. And then once it's designed and built, then we can do some post-occupancy to check, is this really working how we intended? So lastly, we have a couple more resources we were considering to mention if anyone's interested in diving further. But we hope that those ideas gave some food for thought in this interesting, complex, and emerging field.